Hello and welcome to another YouTube tutorial for those studying acute medicine. My name is James Piper. I'm a Senior Fellow and Clinical Lecturer in Acute Medicine based at the Royal Free London and the Medical School of UCL. When we think about acute toxicology, we often think about a variety of things. So patients who have had too much of something, have been poisoned with something, and so this often has significant societal and medical implications, as we'll talk about shortly. So this case is all about acute toxicology. Today, I'm going to talk about the epidemiology of UK poisonings, the approach to a poisoned patient, specific antidotes and poisons, and I'm also going to go through some SBA type clinical questions at the end of this talk. So patients presenting with poisonings, and obviously appreciating that poisonings covers a broad brush of presentations and toxins. There are approximately 160,000 presentations to hospital per year, and sadly there are 2,000 deaths in the United Kingdom due to poisoning per year. In a more broader social policy context, there are 270,000 UK residents in contact with drug and alcohol services, and this is data from 2017-18, 590,000 UK residents in contact with alcohol services, and just to give you a bit of a reference figure, there are about 180,000 UK residents using crack cocaine in 2011. So why is toxicology an important area to cover? Well, as I've already said, it's a common presentation to acute and emergency medicine departments, but also it covers important aspects of social and legal policy. So, for example, from the law point of view, obviously drug policy and law is set by HM government and the Home Office of the UK. And for example, I've shown on there a picture of the Drugs Prevention Misuse Act from 1964. But also toxicology and poisonings, overdose and drug use and alcohol use can have significant social policy consequences. And so, for example, this is an advert on the left for a public meeting for a Welsh community, or to discuss drug and alcohol use in their area, and there are concerns locally about targets for violence, trafficking, drugs, use of and abuse of vulnerable people, and exploitation, county lines, gangs, and so on. So there are significant overlays across all aspects, both clinical medicine, law, and social healthcare policy. So Talkspace you might be familiar with, and if just as a heads up, if you weren't aware, if you have an NHS email account, you can now register for the Talkspace app to go onto your phone, but you do need an NHS email. When we look at Talkspace inquiries for 2019 and 2020, these were in summary the top 10. So most commonly would be paracetamol, and again, paracetamol remains a common but can be lethal toxin when presented to hospital. Ibuprofen, sertraline or an SSRI, diazepam, quetiapine, codeine, pregabalin, mirtazapine, propranolol, and amitriptyline. But it's also important to recognise as well that for those studying in acute medicine, not only do we deal with toxidromes from prescribed medications, but of course we also deal, perhaps more commonly at times, we deal with non-prescription toxins. So for example, we may deal with traditional medicines, herbal remedies, Chinese medicines that may cause drug-induced liver injury and toxicology. Often their evidence base is unclear, and so as a general rule, I tend to advise patients significant caution in using non-prescribed drugs. Then you have the more classical recreational drugs such as cocaine, which is what's shown here, ketamine as well. Also you have what are described, quote, in harder drugs, close quote, such as heroin, methamphetamines, MDMA, and other synthetic drugs such as ecstasy, and these newer synthetic cannabinoids such as spice, which has become quite popular but can have significant toxic side effects. So thinking about our acute medical approach to a poisoned patient, then of course those of you who've watched any of my videos or been to any of my tutorials will be familiar with the ABCDE approach to any acute illness, and there are three main strands of treating and managing a poisoned patient. First one, of course, is to resuscitate the patient, and that might be with aggressive fluid resuscitation, airway protection measures such as intubation and ventilation, and also performing advanced life support and defibrillation if necessary. Doing something to reduce absorption of the drug or promote excretion. So reduce absorption of the drug might be by giving activated charcoal, for example, if the patient attends the emergency department within 2 hours of the overdose. Or it might be we enhance clearance by using hemofiltration mechanisms. Some toxins will have an antidote. Most commonly, for example, people are aware of naloxone, given as an antidote to opioids. So this was a summary figure of the ABCDE approach. Airway, so that will include airway protection measures. Patients will need high flow oxygen, but maybe a naso and oropharyngeal airway. These patients are at high risk of aspiration. If their breathing rate is particularly low or high, then they may need an arterial blood gas taking. In extreme circumstances, they'll need at least cardiac monitoring, and otherwise they may need cardiovascular support, such as through inotropes or vasopressors. Patients who have had poisonings are prone to hypo and hyperpyrexia and glycemia, also prone to seizures and other issues which I'll talk about in a moment. There also may be evidence of traumatic injury, injection sites, and so on, or evidence of snorted drugs on inspection of the nose. So it's important, of course, when approaching any acute medical patient to think about your approach. So first of all, obviously you guys will all be familiar with taking a good history, particularly in a poisoned patient. But it's important to remember that in these particular cases, similarly to dealing with a patient who has cognitive impairment, the history may be unreliable, it may be distorted in time, it may be deliberately vague if the patient, for example, has psychiatric comorbidity, doesn't particularly want treating, and so it may be that you need to rely on witnesses, third-hand notes, paramedic reports, ED notes, and so on. So it's important that you consider where the reliability of the historical evidence that you are given. In some circumstances, the patients will need airway protection, and so, for example, there is a high risk of aspiration if the patient becomes obtunded, so these patients may need intubation and ventilation to protect them from aspiration. There's also a high risk of seizures. So again, this is where airway protection can be important, because obviously again, where patients have seizures, there's higher risk of aspiration. It's also important when a patient comes into the emergency department to check their medical records, their summary care record, and this is because they may have taken a toxin for which they are allergic, and or for example, if they take regular prescribed medications, there may be significant interactions with what it is that they have taken. Sometimes these interactions can be quite difficult, so you'd obviously contact the UK Poison Service or the National Poisons Information Service. So now thinking about more specifically about toxidromes, and toxidromes basically describe the clinical presentation that you might have to help you to elude which toxin the patient has taken. So going through our ABCD assessment, obviously airway is something we've already just talked about, but for respiratory rate, for example, patients can hypo or hyperventilate, and these are some of the toxins which will cause hypoventilation, and they include opiates such as morphine, alcohol, and benzodiazepines such as diazepam and lorazepam. Hyperventilation is often seen in metabolic acidosis, and it's not always due to poisonings, but a large number of toxins will cause metabolic acidosis, which may in turn drive up the respiratory rate. Other specific poisons which may cause hyperventilation include aspirin, paracetamol, ethylene glycol, or antifreeze. You'll also see hyperventilation in gastric aspiration and also carbon monoxide poisoning. With regards to your heart rate, bradycardia can be seen in beta blockers such as bisoprolol, digoxin, and opiates. Tachycardias can be seen in drugs such as tricyclic antidepressants, theophylline, anticholinergics, caffeine, lithium, and digoxin. Note that digoxin is in both bradycardia and tachycardias, and this can be a slightly confusing phenomenon. But again, the reason that you see digoxin as an example in both is that it depends on what time you're assessing them with regards to how much they've ingested and over what period of time, and at what point they're reaching the therapeutic maximum level. So most commonly in toxicology, the most common cardiovascular finding is hypotension, but there are drugs again which are likely to cause hypertension. So in the event or finding of a high blood pressure, you'd want to be potentially asking about the patient taking cocaine, amphetamines, or ecstasy, or a combination of the above. Pupils can cause pinpoint pupils are seen by opiates and organophosphate poisonings, although organophosphate poisonings in tertiary and urban centres are relatively rare compared to more rural and farming communities. Dilated pupils can be seen in alcohol, tricyclics, anticholinergics, and LSD or acids, as it's known. So pyrexia can also be, again, a common finding in poisoning, and these are some of the most common causes of a pyrexial patient. And these include MDMA or ecstasy, paramethoxyamphetamines, which are stimulants with psychedelic effects, cocaine, amphetamines, or methadone, otherwise known as MCAT, and its derivatives. It's also important to remember that how people refer to drugs. So as you can see, methadone can be known as MCAT, amphetamines can be known as ice, crystal, MDMA can be known as ecstasy, or in the reverse. So there are also lots of synonyms that are used to describe a drug. So again, it is important that you are aware of these, and also to make sure that the any descriptors that are used by the patient you write down, and then make sure you're clear about what it is you think the patient has taken, either one or a combination of drugs. Also important to ask about combination of drugs. Patients will often take, depending on what their planned activity was at the time of taking either poisoning or the drugs. It may be, for example, we often see, for example, methamphetamines used with GHB, for example, or gamma hydroxybutyrate. So level of consciousness. So some toxins will make a patient more drowsy, and these include alcohol, insulin, benzodiazepines, opioids, gamma hydroxybutyrate, and metabolic sequelae such as seizures, hypoglycemia, hyponatremia. And again, for example, ecstasy is a good example of causing acute hyponatremia, where the patients drink lots of water whilst taking ecstasy and get a profound water toxicity and give them hyponatremia, which in turn can cause seizures if they drink enough water. You also have hypoxic injury. Toxins that make patients more agitated include amphetamines, caffeine, cocaine, LSD or lysergic acid diethylamide, and cannabinoids as well. But also it's important to think about other things that may have happened. So typical presentations to ED and thus to acute medicine are this patient was found collapsed in the street, ... And so it's important to think about other things that may have happened. What was it they were doing that day, that night? What occurred in the preceding hours before presentation to the hospital? Who else were they with? Was it a party? Were they at a nightclub? Were they on their own? Do they have known drug habits? Were they with someone reliable? Where did their drugs come from? And so on. So it's also important to think about the possibility of head injury. And you can see here on this CT here, this is a picture of a CT of a patient who's fallen and got a subdural hematoma. Also, it's possible that patients have been assaulted. They may have injuries, some of which may be occult. So, for example, ruptured spleen, for example. There may also be evidence of sexual violence or a history of sexual assault or violence. It's possible that patients have had seizures. So, for example, in the case of hyponatremia and hypoglycemia, there may have been cardiac dysrhythmias, stroke, for example, in cocaine. There also may be psychological factors to the patient's toxidrome, such as suicide or an accidental overdose. There could be hypothermia. So, for example, a patient who is found collapsed in the middle of the night, particularly at winter time, have been in a nightclub, having taken lots of ecstasy, been very sweaty, collapses and loses lots of body heat rapidly and develops hypothermia. Also rhabdomyolysis, so as evidenced by a raised creatinine kinase, which can cause a significant kidney injury, and this can be from prolonged seizures or muscle injury. So we're just going to talk about a little bit now about some of the specific poisons and their management. I'm going to talk about paracetamol overdose in a bit more detail than some of the others, partly because paracetamol remains one of the most common causes, but yet still one of the most lethal causes of overdose in the United Kingdom. Some of you may remember that the paracetamol is also covered in the Toxins case, or Megan Jenkins, in preparation for practice. So the trouble with paracetamol is it's a very good antipyretic. It also has reasonable good analgesic effects, so its utility is very good and is part of the analgesic ladder, as you'll all be familiar with. From a toxicology point of view, the trouble with paracetamol is that it's widely accessible and easy to store. Therefore, a patient can store large amounts of paracetamol over a period of time and is very unlikely to be found or show evidence of toxicity until after they've taken their overdose. Now, the toxicity of paracetamol does, however, depend on the amount, the type of exposure, and what this means is that you need to try and get from your patient a detailed history as to whether this was single type of exposure, so i.e. your patient took, say, 15 grams of paracetamol all in one go, with or without alcohol, or staggered. So, for example, the patient felt suicidal and started taking tablets at, let's say, 10 p.m., then took further tablets at midnight, further tablets at 2 a.m., and so on and so on. It's important to calculate the milligrams per kilo of exposure, and this is because it does help you recognize patients who can go home, and also patients are likely to occur serious toxicity. And the threshold is generally considered as per ToxBase at a less than 75 milligrams per kilo is unlikely to cause serious toxicity. But again, it does depend on, and you need to pay attention to again whether this was single or staggered. I have a much lower threshold for treating in a staggered overdose as I do single episode paracetamol overdose. So clinical features of paracetamol poisoning, the most common being nausea and vomiting. Sometimes after a couple of days and the patient presents, you'll have evidence of hepatic necrosis, such as a very raised ALT or AST, right upper quadrant pain, jaundice, acute kidney injury, and in severe cases, hepatic encephalopathy, liver failure, which can be further demonstrated by acidosis and hyperglycemia, as well as the AKI, jaundice, and hepatic encephalopathy. So when investigating a paracetamol poisoning, you need to wait 4 hours from the last ingestion, particularly if the patient has had a single episode of paracetamol overdose, because otherwise interpretation is not possible. But the most important investigations from a blood's point of view to take for a paracetamol overdose, assuming it's just paracetamol, again, always have a low threshold for assuming about other toxins and probing the patient carefully about whether they've just had paracetamol and the timings. Patients, particularly, for example, remember if they've had alcohol, are likely to be confused or not remember the time of their poisoning or their overdose. So again, always be sympathetic, empathetic, always be cautious, and to a degree have a healthy degree of cynicism, just to make sure, and that's in order to protect your patients as opposed to thinking your patient's a liar. Investigations that are minimum include paracetamol level, urea and electrolytes, bicarbonate, and this can be obtained via a VBG or a blood sample, liver function tests, INR, and full blood count. Obviously, if you are concerned that the patient is poorly and you want to check a lactate and bicarbonate and pH level, then obviously a VBG is the quickest test to do and will give you the quickest result. Now, what you do, some of you may be familiar with the treatment nomogram for paracetamol poisoning, and this basically determines your plasma paracetamol concentration in milligrams per litre on the y-axis and time since the overdose in Y, or at least the last paracetamol. And you can see that this is why if you look carefully at the graph, you'll see where the treatment line curve stops at 4 hours and 100 milligrams per litre. Interpretation before 4 hours cannot be accurately done, and therefore that's why the 4-hour mark is important. Basically, what you're going to do is you're going to take the plasma concentration of paracetamol at 4 hours, and then you're going to read off the line. So, for example, if the patient at 4 hours has got a blood paracetamol level of 40 milligrams per litre at 4 hours, this is below the treatment line and does not require treatment, patient can be often discharged, assuming they don't need to see psychology or psychiatry. It's important also to bear in mind about patients' pre-existing liver disease and the presence of a raised ALT. If the patient has an elevated ALT that's acute, consider use of n-acetylcysteine regardless, as this suggests hepatic injury or implies the overdose may have been taken earlier. Now, some patients will have a chronically elevated ALT, so for example, chronic liver disease and alcohol use, and these sorts of patients should either be treated anyway and or discussed with the National Poisons Information Service. So n-acetylcysteine is also known as Parvalex, is a standard antidote for paracetamol poisoning. In advanced cases of paracetamol poisoning, hemodialysis may be necessary, as advanced paracetamol poisoning can cause renal failure and hepatic encephalopathy. An infusion is normally administered over 21 hours or until the ALT normalizes. And the standard infusion, again, you don't need to know this off the top of your head, but it'll be very familiar to you when you spend some time in the acute and emergency medicine departments, both at undergraduate and postgraduate level. The first doses are 150 milligrams per kilo over an hour, 50 milligrams per kilo over 4 hours, and 100 milligrams per kilo for 16 hours. Some patients will present to the hospital acutely in liver failure, and these are the list of indications for criteria for liver transplant referral. I think before I read them out, I think it's just important also to say that I'm sure my colleagues in hepatology would say that if you ever have any concerns about a liver patient or that a patient is going into liver failure, it's always better that you discuss the patient with them so that they potentially can organise transfer of your patient to their liver centre in case they do deteriorate and need a transplant. But the criteria are as follows: an arterial pH of less than 7.3, hepatic encephalopathy grade 3 or 4, serum creatinine of greater than or equal to 300 micromoles per litre, a PT of greater than 100 seconds, and a lactate of greater than 3 millimoles per litre on admission, and as I said, or any concerns about liver failure or your patient. So now thinking about the other toxidromes, and these include SSRIs. So for example, this includes sertraline, citalopram, fluoxetine. Clinical features of SSRI poisoning include gastrointestinal upset, tremor, agitation, sweating, dizziness, dilated pupils, altered blood pressure, and hyperthermia. Investigations primarily are going to be cardiac. So as well as doing all your standard bloods, the most important investigation to do in any poisoning is also to do an ECG. The reason that ECG is particularly important in SSRI toxicity is that you can get a prolonged QT, a widened QRS, torsades de points, and biochemically you can get an elevated creatinine kinase. The management of SSRI toxicity is to replace any electrolytes, fluid resuscitation. If the patient develops torsades, and you give them intravenous magnesium. I have seen a few SSRI poisonings. Patients tend to be very agitated and often will need diazepam and or haloperidol to calm them down. Ibuprofen, although relatively common, often we don't see ibuprofen as much as we do certainly paracetamol and other toxidromes, but again, a common drug, readily available and easily hidden and stored. Features of ibuprofen toxicity, most commonly nausea, vomiting, and epigastric pain. Also, in significant overdose, ibuprofen can cause GI bleed, tinnitus, and precipitate an exacerbation of asthma. AKI is rare but can be serious. Again, investigations are primarily cardiac and biochemical, and they include ECG changes such as ventricular fibrillation, ventricular tachycardia, and ST changes. Metabolically, it can cause an acidosis. Management of ibuprofen overdose includes IV fluids, intravenous bicarbonate, and what's described as supportive care. Now, supportive care is a phrase that you will hear a lot in acute medicine and when dealing with poisonings. And supportive care effectively means that there's no specific antidote, but you do what you can to protect your patient. So this might be intubation ventilation, might be paralyzing and sedating your patient. It might be putting a central line in and giving them antiarrhythmics such as amiodarone. It might be that they need blood pressure support such as vasopressors or inotropic support and hemofiltration. Supportive care is usually can be more simpler than that, such as just giving IV fluids, observation, and replacing any electrolytes. So supportive care does go from the extreme of fairly straightforward admission for IV fluids and monitoring all the way through to advanced level 3 care in a critical care environment. So cocaine, a fairly common drug that's used recreationally. Clinical features include tachycardia, hypertension, chest pain, myocardial infarction, and acute aortic and coronary artery dissection. Again, ECG changes are particularly common, such as VF, ventricular tachycardia, and ST changes. Management will often require benzodiazepines, and if they are profoundly hypertensive with the cocaine use, then the patient may need a GTN infusion and or a labetalol infusion in severe hypertension. If there are concerns about myocardial infarction due to cocaine, then you should also give them the ACS protocol. It's also really important to be able to have an honest and frank conversation about with your patient about the drugs that they've taken and their source, whether they change dealers, whether they have upped or been using their drugs, have they been using things in a combination, and whether anything was out of the ordinary from their dealer. And this can feel quite a surreal question to ask, but actually it's really important. Because actually by asking questions like this, the patients will know that you understand their presentation and understand their drug use. And also it's important that if you ask questions like that, hopefully they may be more transparent about what they've potentially taken. But also more importantly, from a toxicology point of view, often drugs such as cocaine, methamphetamines are often mixed with drugs. So when I trained up in Blackpool many moons ago, there was a famous bout of heroin that was had accidentally become contaminated with anthrax. Sometimes in drugs you can have botulism. Tetani contamination. They can be mixed with other medications such as phenytoin, lidocaine, baking powder, baking soda, and other combinations of drugs. So, it's important that you also appreciate, as well as the drug itself, actually it might be the drug per se that's not causing the toxicity, but actually it could be something like lidocaine or phenytoin toxicity that the drugs may have been cut with. So let's just go through some antidotes now. So the most common one that you'll be aware of is opioids, and the antidote for that is naloxone. So naloxone is a opioid antagonist and is used frequently in concerns of about opioid toxicity. Basically what happens initially, the adult dose is often given either IV, subcutaneously, or IM. 400 micrograms and 800 micrograms for up to 2 doses at 1 minute intervals. And again, this can be increased, and sometimes patients need an infusion of naloxone, and this is important because naloxone has a short duration of action, and therefore repeated doses or infusion may be necessary to reverse the effects of opioids with a longer duration of um, of action, such as modified release drugs. In benzodiazepines, you use flumazenil, and this is administered as a dose for adults with 200 micrograms to over 15 seconds, and again can be increased with further doses. It's important also to realize, however, that life-threatening conditions such as raised intracranial pressure and status epilepticus controlled by benzodiazepines is actually a contraindication to giving flumazenil. Side effects of flumazenil include anxiety, diplopia, dry mouth, eye disorders, flushing, headache, sweating, hyperventilation, withdrawal syndrome as well, and seizures as well. Digoxin has a specific antibody, and this is known as digibind or digoxin antibody fragment. A lot of drugs often have no antidote, such as gamma hydroxybutyrate. If there is significant respiratory depression with GHB, then the patient will often have a brief period of intubation and ventilation. Lead has an antidote of chelating agent called sodium calcium edetate, which is given intravenously. Iron is desferrioxamine, and in warfarin, again, less commonly prescribed than the DOACs now, but you'd use prothrombin complex concentrate, or PCC, otherwise known as Beriplex, to administer your warfarin antidote. Vitamin K can also be used to reverse warfarin. However, it's important to realize that vitamin K can take 6 hours to work. And so therefore, if your patient needs immediate reversal, then you must use PCC and not just vitamin K. So let's go through some SBA questions now. So you will be familiar with the structure of these. I'm going to give you a question and I'll give you some time. And so just pause the video whilst you're deciding your answer. So I've got a couple of questions for you. Here we go. Question number 1 is a 25-year-old is found collapsed on the street. On arrival to the emergency department, he is unconscious and snoring. His pupils are 2 millimeters bilaterally. His respiratory rate is 3. Which antidote is the single most appropriate? Is it A, activated charcoal, B, benzodiazepines, C, flumazenil, D, naloxone, or E, supportive care? Pause here until you have the answer. So the answer is D, naloxone. So this has a fairly classic story of opioid toxicity given the low level of consciousness, low respiratory rate, and his pinpoint pupils. Activated charcoal is not appropriate here. He's unconscious and snoring, therefore giving oral activated charcoal could be dangerous. Given he already has a low level of consciousness, benzodiazepines, of course, would be entirely inappropriate. Flumazenil, there's no evidence of benzo toxicity. It is more likely to be opioid as opposed to benzos. And also, yes, the patient may need supportive care, but the question says which antidote, and supportive care is not an antidote, it's a management strategy. Next question. A 35-year-old female presents to acute medicine having taken some of her grandmother's tablets. She appears confused, has dilated pupils, hypotension, and requires a urinary catheter. An ECG records a QRS complex of 200 milliseconds. Which of the following was the single most likely toxin? A, amitriptyline, B, bisoprolol, C, ferrous sulfate, D, diazepam, or E, erythromycin. Pause here until you have the answer. And the answer is A, amitriptyline. So there are some clues here. So taking her grandmother's tablet. So the reason this is a slightly historical reference to the fact that TCAs used to be prescribed in fairly tall order for older generation as an antidepressant. Amitriptyline is now very rarely used as an antidepressant, but is used for things like neuropathic pain and things like that, which I'll come on to shortly. She has a classic toxidrome with TCA overdose, including confusion, dilated pupils, hypotension, urinary retention, and a broadened QRS complex. Bisoprolol, there's no evidence of bisoprolol toxicity. Again, although she has hypertension, in bisoprolol overdose, you don't get the dilated pupils and you don't get urinary retention. Again, ferrous sulfate, similarly, this toxidrome is not in keeping. Diazepam, again, you would not get dilated pupils and a prolonged widened QRS complex and urinary retention. And erythromycin, that can cause prolonged QT interval, but not any of the toxidromic features that are shown above. So tricyclics, or antidepressants, are otherwise known as TCAs, are highly toxic by ingestion, and so, as I was saying, are less routinely prescribed. You basically have severe toxicity from sodium channel blockade, which can cause arrhythmias and cardiovascular collapse. The most common findings on an ECG include prolonged PR interval, QRS complex, and prolonged QT. Clinical features also show hypotension, and laboratory findings include low potassium and metabolic acidosis. The treatment this is one of the few occasions in which sodium bicarbonate is recommended early on, and this is to give 500 to 100 ml of 8.4% sodium bicarbonate, and the patient may need multiple doses. This is an ECG, very typically of someone who is had a significant TCA toxicity. As you can see, she has a very broad complex tachycardia here. Next question, a 50-year-old is referred to acute medicine having ingested paracetamol all at once. After being taken at 4 hours, blood levels show a paracetamol level of 60 milligrams per litre with normal urea and electrolytes and liver function tests. His INR is 1.2. He is alert. What is the most common appropriate course of action? Is it A, admit for observation, B, admit for n-acetylcysteine, C, administer activated charcoal, D, discharge home, or E, repeat blood tests? Pause now until you have your answer. And the answer is D, discharge home. Given the paracetamol level of 60 milligrams at 4 hours, this is below the treatment line. He's using these LFTs and INR are all normal. He is clinically well, so he can be discharged with mental health liaison team input and then discharged thereafter. Final question. A 20-year-old is admitted to the emergency department having had a significant quantity of alcohol. On arrival, an oral pharyngeal airway is inserted. An ABG and chest x-ray are requested, and the chest x-ray is on the next slide. What is the single most likely chest x-ray finding? Is it A, aspiration pneumonitis, B, basal atelectasis, C, community-acquired pneumonia, D, COPD, or E, normal? Have a look at the x-ray now and then pause until you have the answer. This is the patient's chest x-ray here. And the answer is A, aspiration pneumonitis. So let's just have a quick look at what we've seen. We know that he's had a significant quantity of alcohol, therefore he's likely to have delayed gastric emptying. He is young, so should not have any lung pathology otherwise. He's needed an oral pharyngeal airway. So aspiration pneumonitis is most likely, and this is the most common occurrence after aspiration, is you get a pneumonitis effect, and then in the sort of 24 to 48 hours afterwards you develop an aspiration pneumonia. Basal atelectasis, there's no evidence of that. Community-acquired pneumonia, there is no focal consolidation. He'd be too young for COPD, but clearly it's not normal. He has bilateral multi-lung changes. He's got a sort of like a fine shadowing on both of his lungs. So similarly to ARDS, and this is the pneumonitis picture that you can see on the x-ray. Okay, so thank you very much for listening. I hope you found this talk useful. If you have any questions, of course, you can email me directly at james.piper@ucl.ac.uk. I wish you all the very best, and this will be uploaded to YouTube and the UCL Moodle. Take care, everyone. Bye-bye.